Hello everyone, this is Dr. Humanist again. Let us now study about the pathogenesis of PCOS or PCOD. Okay, so we'll discuss one by one all the factors. First one is genetics accessibility. Okay, so in that we see that there is a 71% of concordance in monozygotic twins and 34% in dizygotic twins. Okay, so what will genetic effects will do? First one is there is insulin resistance. Okay, next is there is a increased tendency of fat accumulation in the body, like visceral fat. And third is there is increased serum LH levels. Okay. Other than that, there is a lifestyle changes if we see, like overeating, obesity, sedentary behavior. Even that will lead to insulin resistance, as we know, and there is increased fat accumulation in the body. Okay, we'll see what all each factor will do. Now, when there is increased estrogen, it will, apart from the metabolic syndrome like type 2 diabetes, acanthosis nigricans, there will be increased androgen production. Insulin wants there should be more androgens in the body. So when there is insulin resistance, there is a more insulin production, right? So it will decrease the sex hormone binding globulin, that is SHBG. So this binds the androgens and keep it inactive. When these binding globulins are decreased, that means there is an androgen increase, right? So this is one thing, and directly it will stimulate the theca cells for the production of more and more androgens. Okay. Next thing, as I said, there is a because of the genetics. So LH is less, and even because of the increased estrogen. Why there is increased estrogen? Because the fats, visceral fat, no, there is a peripheral conversion of E2 to E3, that is active form of the estrogen. So more and more estrogen comes into the blood. So estrogen will increase the LH itself by positive feedback mechanism. Now these two things, one is because of genetics and because of the increased estrogens. So LH will is increased, right? So it will, what it will do is it will decrease the conversion of testosterone to estrogen, which is done by the FSH activated granulosa cells. But FSH is decreased, so granulosa cells are not working here more. That's why the conversion doesn't happen. So testosterone are increased by, in that way. So all three effects, because of insulin resistance, insulin will cause more and more theca cells will produce more androgens. It will decrease the SHBG from the liver synthesis, and because there is LH increase, so testosterone is not converted. So now there is a state of hyperandrogen. That will lead to symptoms like hirsutism or alopecia, skin thickening, and acne. So because of this, no, there is increased androgen and estrogen too early in the menstrual cycle. It is already high because we need a pulse, like decrease and increase for the proper menstruation cycle to happen. So there is early separation of FSH, and because of this, there is a cessation of follicular growth also, and there will be unpredictable ovulation, can even lead to infertility. So because there is a cessation of follicular growth, there will be polycystic ovaries, the cyst will form. And next is irregular menstruations. Also infertility, dysfunction, bleeding, risk of endometrial cancer and all. So when we see the Rotterdam criteria for diagnosis of PCOD, three things are there. There is oligomenorrhea or anovulation. Second is the symptoms or laboratory proven hyperandrogen state.